Welcome back, everybody. Before I introduce the next session, I'd like to highlight a feature of the conference that's available in the portal over the next couple of days. The Meeting Hub is a feature in the timeline that allows you to connect and talk to other delegates. So I really encourage you to connect with your peers and counterparts, and the IPA team particularly are in there and happy to answer any questions you have. Don't forget to type your questions in the Q&A function. We didn't get to them all in the last session, but we really will try our hardest. So now I'd like to welcome Julia Hume, who's the chair of our first keynote presentation. Julia is the Executive Director of Costing and Data Infrastructure and leads the teams responsible for the function of the costing, data acquisition and IT infrastructure at IPA, and has worked on the NHCDC extensively in both the public and private sectors. She holds a Bachelor of Applied Science in Health Information Management and a Master of Political Economy from Sydney University, and she's previously held roles in the health sector, including working in health insurance and cancer research. She's also worked in international development sector in several post-conflict countries. And if this was a face-to-face conference, I'd encourage you to ask her questions at the drinks tonight, but you'll just have to save those for next year. Over to you, Julia.
Thank you, James. Good afternoon and welcome to the first keynote presentation of the conference. I'm Julia Hume, Executive Director of Costing and Data Infrastructure at IPA. It gives me great pleasure to introduce the first keynote session of the day, Sustainability in Healthcare and Indigenous Perspective, presented by Dr. Amohia Boulton, hailing all the way from New Zealand. Dr. Amohia Boulton is the Director of Whakaui Research Services, an iwi-owned and mandated health research centre in Wanganui, New Zealand, and the 2021 recipient of the Royal Society of New Zealand's Te Tohu Raparoa Medal, awarded for her demonstrated leadership, excellence and contribution to advancing Maori health knowledge. A health service researcher of some 20 years, Dr. Boulton's research focuses on the relationship between and contribution of government policy to improving wellbeing outcomes for Maori. Her recent work has explored areas such as research ethics, the place of Maori approaches to wellbeing and traditional healing in the publicly funded health system, and the role of data in healthcare decision-making. She is currently leading a 5-year Health Research Council of New Zealand funded program entitled Kia Puawai Aki Ngā Uri Wakatupu, Flourishing Future Generations, which seeks to identify the conditions necessary for a health system shift, a shift where resourced action is targeted to achieve equity of health outcomes for Maori. Dr. Boulton is also an adjunct professor at both the Health Services Research Centre, Victoria University of Wellington, and in the Faculty of Health and Environmental Sciences at Auckland University of Technology, and holds a number of governance positions, including membership of the Healthier Lives National Science Challenge Governance Group, Kahui Maori, and on the Maori Advisory Board of the Malahan Institute of Medical Research. We hope you enjoy this valuable and insightful perspective on the sustainability of healthcare systems.
Ka te kei runga, kei ngā maunga whakahei, kei ngā awa whakairo whenua, kei ngā mātā waka I Wanganui a tātou, tēnā koutou. E mihi ana hau ki te haukainga o Iarohe. E mihi ana hau hoki ki o koutou kaitiaki, ki o koutou tupuna, ki o koutou kaumātua kuia. Nō reira, koutou mā, tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko waiau, e rua oku maunga, ko mauau te maunga ki te tau o tōku whaia, ko taranaki te maunga ki te tau o tōku matua. Ko wairoa, ko urunui, ngā awa, ko Ngāti Ranginui, Ngaitirangi, Ngāti Pukenga, Ngāti Mutunga, me te ati awa o te waka Māui o Kuiwi. Ko Amohia Boulton tōku ingoa. In the language of my people, I greet you. I acknowledge your ancestral mountains that shield you. I acknowledge the rivers and the waterways that carve their way through your land and bring life. I acknowledge you, the people from the four winds who are gathered today for this conference. I also acknowledge and greet the traditional owners of the lands that each of us gather, and I acknowledge the wisdom and the knowledge and the teaching that those traditional elders have to offer us. As is the custom of my people, I've introduced myself by my mountains, my rivers, and my tribal groupings. On my mother's side, my mountain is Mawao, and this means trapped by the dawn's light. Some of you may know this mountain as Mount Wanganui in the Bay of Plenty on the North Island of our country. My river is Wairoa, and my people from these lands are Ngāti Ranginui, Ngāi Te Rangi, and Ngāti Pukenga. On my father's side, my ancestral mountain is Taranaki, or Shining Light. This is the mountain that overlooks the city of New Plymouth on the west coast of the North Island. My river here is Urenui, and my people that have descended from this place are Ngāti Mutunga and Te Aotearoa o Te Waka a Māui. And my name is Amohia Boulton. As Māori, the Indigenous people of New Zealand, we introduce ourselves in this way through reciting our lands and our waters, our tribes, for at least two reasons. The first of these being so that anyone listening can, if they recognise those places that we have recited, figure out how they are connected to me. Now, were I speaking to a Māori audience, you would be able to work out from what I have just recited how you and I are connected. And you would, as Māori, be making those connections through your whakapapa or your genealogy to mine. The making, the acknowledging, and as time goes by, the cementing of these connections and relationships is an intrinsic and critical component of how we maintain the well-being of our society and maintain our societal bonds. The second reason we begin with this recitation is that in naming my mountains, my rivers, my waterways, and my lands, I am asserting my genealogical connections to those specific places and features, and I'm asserting my rights and responsibilities to those places. Again, this is a critical part of our society, ensuring that each generation understands its role in the conservation, the preservation, and the guardianship of those places, spaces, and sites of significance. While I touch on the importance of our connection to the land only briefly here, it is a key theme throughout my presentation. And that's because it goes to the very heart of an Indigenous worldview of sustainability and an Indigenous worldview of health and well-being, and therefore has implications for how we construct our healthcare systems and ultimately how we provide healthcare to Indigenous peoples. There's one more acknowledgement that I need to make before I begin proper, and that is to the people of Ngāti Hauiti. So this is a tribe in the lower North Island, and it is the tribe I work for, a visionary tribe who decided some 17 years ago to start their own health research centre to focus on issues of concern to their people. And as Julia said, today Whakaua Research Services is the only tribally owned health research centre in New Zealand. We have a small staff of 10 people, 6 of whom are researchers, and we undertake kaupapa Māori or kaupapa Māori research to look at health services, health policy, and community health services, really. Oh, that didn't work. Why didn't that work? Technology. There we go. Sorry about this. Yep. It's in my role as a Māori health researcher that I was approached to speak to this conference. And I want to extend my thanks to the Independent Health Pricing Authority, in particular to James Downey for the invitation to speak today. In the course of this presentation, I'm going to cover a number of topics as I explore the theme for the conference, primarily sustainability, but also the themes of innovation and collaboration. I'll start by making some introductory comments and context-setting remarks, and then I want to look at the notion of sustainability, particularly from a Māori perspective, before looking at how Māori view the notion of health and well-being. Then, having given you a really rapid outline of how Māori think about sustainability, of health and well-being, I will discuss how this thinking has informed and influenced our health system over the course of the last decade, but more importantly, the last 4 years in particular. And finally, I will conclude with a series of principles which I would argue, if enacted appropriately and resourced appropriately, can help give effect to the creation of a more sustainable health system, one which values indigeneity and the role that Indigenous people have in directing their health and their well-being. So if I can start with a few remarks about my presentation and the thinking that informs it. As has been said, I'm a health services researcher. I undertake qualitative health research, and the work that we do in our centre focuses almost exclusively on aspects of health service provision and health policy that impacts Māori. Topics of particular interest to our team include the integration of rongoa Māori or traditional Māori healing into Western or the mainstream health system, issues of equity in health service provision and an outcome, and how to deliver publicly funded health services in a way that best meets the needs and aspirations that Māori have for their own health and well-being. I am not someone who is intimately involved with nor knowledgeable about how Australian public hospitals are funded. However, as a health services researcher, I am deeply interested in the decisions that are made with regard to where our precious health dollars are spent, who benefits from our healthcare system, and why, given we spend so much on healthcare, we in New Zealand at least still experience alarming inequity of health outcome compared to non-Māori in our country. The vision, as I understand it, of the Independent Hospital Pricing Authority is that all Australians have access to a locally controlled health system, one that appropriately funds public hospital services and is sustainable. Furthermore, in funding those hospitals, recognition is given that some patients are more complicated and therefore more costly than others. An obligation to think about sustainability and the sustainable funding and delivery of services for all is therefore very much embedded into the mandate of the IHPA. So what are some of the sustainability challenges that a modern healthcare system faces? From a health services perspective, and again in the New Zealand context, if we think about the total population, these challenges include our ageing and relatively small population, a population that is living longer, often with comorbidities and complex conditions, the desire for better, for faster and more expensive treatments and for therapies, and a challenge that has become even more acute in a COVID-19 world is, for New Zealand, our geographic isolation at the bottom of the South Pacific. So those are challenges for the total population. For Māori, as the Indigenous people of New Zealand, we tend to have a very different experience of our healthcare system. We are a very much younger population. We don't live very long. So the challenges for the total population are not necessarily those that are experienced by us. We also experience inequity as a key factor of our contact with and our experience of the health system. So the challenges that we face as a population, as Māori, require bold and transformative change. Suffice to say, understanding what is meant by sustainability, understanding that even the notion of sustainable healthcare might mean different things to different population groups, is critical to the work of the IHPA. And if I do nothing else today, I want to plant the idea that Indigenous people think about sustainability and health quite differently. And that in turn means that we might require very different solutions to the health challenges that we face. Innovative and collaborative solutions which Indigenous people themselves need to drive. So, before I go too much further, in case it's not already apparent to you, my presentation is based on a specific Indigenous worldview, namely a Te Ao Māori perspective or a Māori worldview. Having said that, I do not profess to speak on behalf of all Māori, nor indeed all Indigenous peoples. This presentation is based on my own knowledge and my own understanding and what I've been taught, and what I know to be true from my experience being involved in kaupapa Māori research for the past 20 years. In my introduction, I talked about our Health Research Centre and that we undertake kaupapa Māori research, producing research evidence of direct benefit to Māori collectives, whether that collective is our tribal owner, it could be other sub-tribes or tribes, could be urban communities, or it could be Māori as a total population. I guess in order to understand what I mean by kaupapa Māori, some explanatory, it's helpful to give an explanation at this point. Kaupapa Māori literally means according to a Māori way. Kaupapa Māori research is at once a philosophical position, a theory, a methodology, and a method of research inquiry. Kaupapa Māori research places Māori values, Māori worldviews, Māori ways of being and operating at the centre of the research activity. It is strengths-based and it is committed to the view that far from Māori being the problem, it will be the solutions, the direction and the leadership that is generated by Māori which will most effectively and positively impact health outcomes for Māori. Unsurprisingly then, kaupapa Māori research or a kaupapa Māori approach is transformative, it is critical, and by extension, it is often regarded as political, as it seeks to improve the position of Māori in contemporary society. In adopting a kaupapa Māori approach to the conduct of the research we undertake, we seek to resist, to challenge, and to disrupt existing mainstream systems. We seek to critique notions of power and privilege, and we seek to confront racism in its many forms. In undertaking kaupapa Māori research, we aim to produce robust mātauranga Māori, so Māori knowledge, which privileges the Māori voice as a means to influence processes, structures, and systems. So that's the philosophical positioning of our centre, and indeed for this presentation today. So let's turn now to the notion of sustainability and what I mean by sustainability, what Indigenous people might mean by sustainability, and see if we're even on the same page when we talk about this word. These images represent some fairly common models of sustainability from the literature. On the left, my left, we have the so-called three-legged stool, where sustainability is the consequence of balancing economic, social, and environmental needs and imperatives. Each of these three pillars of sustainability, the legs of the stool, if you will, are understood to carry equal weight and be equally as important as the other, which is why the stool metaphor is a useful one, because if any one leg is weak, then the whole thing tips over. The belief that economic, social, and environmental factors are all equal and distinct from each other is somewhat dated now, however. And so we've seen the progression to more nested or integrated models of sustainability. Models which depict a more complex relationship between the people, between the economy and the environment, where the economy and the society are subsystems of the larger whole. And it's this last, more integrated model of sustainability that best approximates an Indigenous perspective of sustainability. And even this model doesn't fully capture an Indigenous view. I want to take you back to the start of this presentation where I spoke about my mountain, my waters, and my land. For Māori, these physical aspects of our environment are not merely places that we inhabit or resources that we use to stay alive, to clothe and to feed ourselves. For Māori, the land is literally our mother, who we call Papatuanuku, and the sky is our father, who we call Ranginui. Along with all the living creatures that inhabit the earth, we are the offspring of those two entities. We claim, and the most knowledgeable of our people amongst us can recite, a genealogical connection to the land, who is our ancestor, who is part of our family, who is our relation. An Indigenous worldview holds that as people, we are indivisible from the lands from which we come, the land on which we are born and which we return to when we die. So this mountain, my mountain, is an ancestor, as is the sea from which he rises. And yes, my mountain is a he. And this river, my river, is yet another ancestor. The connection between us and the land as Māori is evident if you know our language. Today, to ask someone's name in te reo Māori, in the Māori language, is to ask ko wai koe, who are you? As in this slide, ko wai o, who am I? However, the actual meaning of the word wai is water. So when you are asking today for someone to identify themselves, to tell you their name, what you are literally asking is, what waters do you come from? Whose waters do you come from? Where are your waters? You may be aware of the river that runs through the city where our research centre is based. That river is the Wanganui River, and it flows from Mount Ruapehu in the centre of the North Island to Wanganui, which literally means large bay. In March of 2017, the New Zealand government enacted legislation granting the Wanganui River legal personhood. This saying speaks to the people, about the people of the river and their connection to it. It talks about the river as an indivisible and living whole from its source in the mountains all the way to the sea, including its many tributaries and all its physical and spiritual elements. It speaks of the connection that we have as people, as all people, to the life that comes from the water, but also to the land. Another illustration of the significance of the physical environment to Indigenous peoples is provided here. These quotes are taken from a piece of research that our team is undertaking at the moment, which is investigating the role and the significance of rongoa Māori, traditional Māori healing, to wellbeing. So Māori perceive natural ecological environment as a medium for physical, emotional, mental, spiritual wellbeing. Caring for the land involves both environmental and resource management expertise and knowledge based on long-held responsibilities and practices around the guardianship, the protection of our natural resources. Furthermore, caring for the land recognises the interconnectedness of the whole environment, where the land becomes a part of the culture and the identity of the people. For Māori, access to the wider environment for health, spiritual well-being and cultural connections is vital. Contact with the land links Māori to mātauranga Māori and tikanga, to our knowledge and our customs, to hinengaro and wairua, to mind and to spirit, and to tinana and to tangata, to our physical body and to people. Land is not only a key component of Māori cultural identity, it is an essential element in our health and well-being. For Māori, similar to other Indigenous peoples, health is not simply the absence of disease. From a Māori perspective, health is all-embracing. It encompasses the physical, the spiritual, the mental, and the emotional. In a Māori worldview, our health and well-being is also determined by our connections, not just to people or to our environment, but to all things, animate and inanimate. Health and wellbeing recognises the interconnectedness between all the elements that make up our world. Health is also understood at the level of the collective, from the individual out to the wider family, which is multi-generational. Hence, we have seen in the last 20 years the emergence of the term whānau ora into New Zealand health policy. The term whānau ora has been defined as the well-being of the extended family, and it is an innovative approach to Indigenous health and social services policy in New Zealand. Whānau ora has been a key plank in Māori health policy, being at once a philosophical position, a model of service provision, and an outcome to which we aspire to achieve. Whānau ora as a policy and as a service approach seeks to empower whānau as a whole and devolve to whānau members self-determining processes to improve their cultural, social, economic and environmental well-being. Whānau ora places the needs of the extended family at the centre of the healthcare experience. For Māori, the ability to determine their own health and wellbeing goals is a right enshrined within the Treaty of Waitangi. So this document was signed in 1840 between a number of tribal chiefs and representatives of the Crown. And while we have had breaches of that treaty since its signing, it is considered today to be one of our founding documents and a critical component of our Constitution. More recently, the rights that are enshrined in our Treaty of Waitangi have also been enshrined in the United Nations Declaration on the Rights of Indigenous Peoples. And I would argue that 3 articles in particular are relevant to the issue of sustainability and health, namely, the right for Indigenous people to be self-determining and in accordance with that right to freely pursue social and cultural development, the right for Indigenous people to take part in decision-making in any matters which would affect their rights, and the right for Indigenous people to improve their social conditions, including health. Given then that we know that for Indigenous people, the health and wellbeing of the individual is linked to the health and wellbeing of the wider collective, to the family, to their community, and even to the lands in which they inhabit and the environment in which they interact. If I've done a good enough job in this little time of showing you that this is how, in fact, Indigenous people view health and wellbeing, then it's not such a huge leap to understand that sustainable health and sustainable healthcare must take cognizance of those collectives, of those environments, and of those landscapes. Furthermore, sustainable healthcare must be concerned with and take cognizance of those elements of a people's culture which keep them well, mentally, physically, emotionally, and spiritually. Elements such as language, as gathering places, our customs and our ceremonies, our rituals and our rites of passage. And the healthcare system must evolve and adapt to find ways to uphold the integrity of Indigenous people and their culture and support Indigenous people to be able to determine and retain autonomy over their health and wellbeing goals. Currently in New Zealand, after 180 years of colonisation, Māori no longer exercise rangatiratanga, or in other words, the ability to self-determine over the most fundamental of our human rights, and that's the right to a standard of living adequate for health and wellbeing. Official and administrative statistics collected in New Zealand continue to demonstrate that not only do Māori lack real agency in determining our own health and wellbeing, the health and disability system itself has failed in its efforts to address its own equity goals. The persistent health inequities between Māori and non-Māori are a stark reminder of the structural and systemic barriers which inhibit us from exercising our rangatiratanga, our ability to self-determine. Some of the statistics which evidence this, there is a 7-year difference in life expectancy, for example, between Māori and non-Māori. Our total cardiovascular disease mortality rate for Māori is twice as high as for non-Māori. Our self-reported diabetes rate is twice as high. and our total cancer mortality rate is 1.5 times higher for Māori than for non-Māori. Inequities are also apparent in differential access to healthcare services and in the types of treatment we are offered once we do present to those services for care. The disparities in health outcome between Māori and non-Māori are explained by a number of factors, including inequitable distribution of health determinants, systemic exclusion, discrimination and racism, as well as the entrenched failure of our health system to adequately address Māori need. So at this exact moment in our country's history, we are implementing a sweeping and whole-scale reform of our health and disability system, one which attempts to embed some of the concepts I've just talked about into our healthcare legislation, into our policy settings, our structures, our funding models, and our decision-making. In the last 2 decades, we have made some attempt at growing the healthcare system's understanding of and ability to respond to Māori conceptualizations of health and wellbeing. These changes, initiatives, policies like whānau ora have sought to embed Māori worldviews more deeply into the funding and the delivery of healthcare. We have attempted to embed Māori decision-making at the highest levels on our district health boards, and we have invested in schemes to grow Māori capacity, and particularly Māori workforce capacity. However, Māori would argue that much more is required in order to reverse the inequities of health outcome that we experience. The changes that are currently underway in New Zealand have their origin in 2 investigations undertaken independently of each other, but both of which concluded that the health system, amongst other things, was not working for Māori. In 2016, the Waitangi Tribunal, a permanent commission of inquiry established under the Treaty of Waitangi Act in 1975, they began hearings on a claim investigating nationally significant health issues. The tribunal observed that as a population group, Māori have on average the poorest health status of any ethnic group in New Zealand. The so-called Y2575 claim sought to identify the cause of persistent inequitable health outcomes and investigated whether, in fact, the legislative and the policy framework which structures our health system had some role to play in that significant inequity of health outcome that we experience. The Health and Disability System Review, meanwhile, was a panel established by the Labour government, and it was charged with 2 tasks. The first, to identify sustainable system-level changes that would lead to better and more equitable health outcomes for all New Zealanders, including Māori. And the second was to shift the balance of our health system from a focus on illness towards one that is focused on health and well-being. Now, I wanted to quickly show you this table. For the data geeks, I am not a data geek, but I wanted to show you this because I touched briefly on the point that the difference in health outcomes between Māori and non-Māori can be explained in part by the inequitable distribution of health and social determinants. While these figures are somewhat dated now, we're having issues with our Māori data in our latest census. Suffice to say, this table provides a compelling picture of the extent of the inequity that is experienced by Māori across a range of socioeconomic indicators. I wanted to put this up because while this conference is concerned with health and the funding of public hospitals and patients who access those services, of course, the wider socioeconomic determinants have a critical role to play in why some patients and some procedures are more complex and more costly than others. Secondly, when we talk about health for Indigenous peoples, as I've tried to establish, you cannot separate our social, economic, and cultural context and our lived realities from any conversations about our health and well-being. The key point of the table is to highlight the significant inequities experienced by Māori, which support the need to do things differently, to introduce and enact bold, courageous, and innovative change in our health system, and I would argue in public policy more generally. The current reforms have been described by many commentators as being the bold and transformative change that is required. And there is certainly a heightened level of expectation on what these changes might deliver for Māori. From this diagram, we can see that at the heart of the health system are whānau, families, iwi, our tribes, and our communities. So immediately, the focus has moved away from seeing health as something that affects and is moderated as an individual experience to a more holistic understanding of health, whereby people are part of a wider collective, whether it be their family, their community, or for Māori, their tribe or sub-tribe. Two entities have been established, replacing our current 20 district health boards. The first is Health New Zealand, an organisation established to run the health system across the entire country, with functions delivered at the national, regional, district, and down to the local level. It will be the responsibility of Health New Zealand to manage all health services across the country, including hospital and specialist services, as well as primary and community care. It is expected that hospital and specialist services will be planned nationally and delivered more consistently across the country, as opposed to what we are seeing now, which has been termed the postcode lottery of health service provision. Primary health, wellbeing, and community-based services will also be planned and then purchased through 4 new regional divisions of Health New Zealand. Each region will work with their district offices located closer to local communities to develop and implement plans based on local needs to improve the health and wellbeing of those communities. And if you look at this diagram, you'll see there is an explicit reference to health and social care, signalling a move away from ill health to focus more on wellbeing more broadly. Significantly for Māori, a Māori Health Authority has been established, a new statutory entity responsible for ensuring the health system works for tangata whenua for Māori people. As part of the Māori Health Authority's mandate, it is charged with developing strategy and policy to ensure better health outcomes for Māori. It is also charged with commissioning of kaupapa Māori services and other services which target Māori communities, as well as co-commissioning services alongside Health New Zealand. It also has a role in monitoring the overall performance of the system in its efforts to reduce health inequities for Māori. Working in partnership, the Māori Health Authority and Health New Zealand will together develop the New Zealand Health Plan, a blueprint for what our health system will deliver into the future. A further feature of the reforms is the intent to partner with Māori in the design and the delivery of health, and for Māori to have a much greater role in the establishment of those structures, those systems, and those processes, which will enable that partnership to be enacted at the local level. So again, right at the moment, we are in the process of establishing iwi Māori partnership boards. These boards comprise representatives from each of the tribes in a specific locality or region. So the people who claim mana whenua status, what is akin to territorial rights or is understood as territorial rights in the region. The boards will have a number of responsibilities on behalf of those tribes that they represent. For example, they are expected, amongst other things, to assess the current state of Māori health in their locality and to determine priorities for improving Māori health. They have a monitoring function whereby they monitor the performance of the health system in their locality, specifically with regard to Māori health outcome. And they also have a role in agreeing a region's overall health priorities and plans, the priorities and plans for the total population, alongside Health New Zealand and the Māori Health Authority. So at a national level, we have the Māori Health Authority planning for improvements in health and monitoring to see if we're tracking on meeting those plans. At the local level, we have iwi Māori partnership boards comprising tribal representatives who also have an advisory, planning and monitoring function. And again, they are charged with assessing how we are tracking on meeting our objectives for reducing health inequities. Equity, excellence, and sustainability are other key features of this reformed system, where sustainability refers to preventing and reducing health need, instead of simply addressing illness and promoting efficient, high-quality healthcare. The ultimate aim for our reforms is pai ora, a state of well-being in which one is said to be thriving or flourishing. Seen here in this model, pai ora is regarded as the pinnacle of what a sustainable health system in New Zealand can achieve. This ultimate aim sits atop the building blocks of mauri ora, health at the individual level, whānau ora, healthy families, and wai ora, our healthy environments. And although the image doesn't necessarily convey this well, the interconnectedness between each of these elements is critical to the achievement of the vision. In other words, to achieve a sustainable health system and a healthy, thriving, flourishing population, we must come to grips with the idea that people and those environments in which we live are inextricably intertwined. So far, my presentation has been very high level, very big picture. So what have we been able to see on the ground in our communities when we build Indigenous, or in our case, Māori concepts of health and wellbeing into our health system? And indeed, what, if anything, does this contribute in terms of the themes of innovation and collaboration? In preparing for this conference, I was asked to consider where I saw the greatest opportunities for innovation in my work. Purely from a health research standpoint, Indigenous knowledges and Indigenous paradigms have much to offer in the way that we see the world, in the way that we go about interrogating and understanding the world, in the types of questions we ask and the types of results we seek. By embracing and providing space for Indigenous knowledge, thinking, processes and practices, we arm ourselves with innovative ways of defining, describing and identifying the problem, and equally we're able to generate solutions to those problems, which might be quite different. Furthermore, by working in partnership or in collaboration with Indigenous peoples, our problem definitions may alter, and therefore our proposed solutions may suit and meet the needs of all peoples and not just the majority. An example is appropriate here. And this example is taken from the Data, Decision Making and Development, or D3 study, which we conducted with 3 DHB case study sites from 2017 to 2020, so slightly before the announcements regarding the health reforms. The purpose of this study was to understand how Māori-specific data routinely collected by DHBs was used by the decision makers and the leaders within those DHBs to inform the decisions that were made about where funding should be used. Our hypothesis was that if those leaders and decision makers had the right data, they would make robust decisions about service planning. And the study had a number of sub-questions about some of the challenges to that, and we also wanted to see if there were any positive examples of data generation. One of our case studies was concerned with oral health data for children at ages 5 and then again at ages 12 to 13. The DHB with whom we partnered on this work had initiated an oral health project based on the knowledge that oral diseases are amongst the most prevalent chronic diseases in New Zealand. Oral diseases are also an excellent indicator of equity in child health. We know, for instance, that in the New Zealand context, the oral health status of a child at age 5 predicts their oral health status at age 26. We also know that despite oral health, poor oral health being readily preventable through primary healthcare services, through health promotion and health promoting behaviours, large disparities exist between the oral health of Māori and non-Māori children. So this graph is just to highlight those disparities in terms of oral health nationally between 2002 and 2016, on average, Māori children aged 5 were nearly 1.5 times likely to have decayed, missing or filled teeth compared to non-Māori children of the same age. By age 12 to 13, the rate had dropped slightly to 1.3 times as likely, but that inequity remains. And interestingly, just yesterday, there was a news item in one of our major daily newspapers reporting that currently more than 3,790 children and adolescents are on a public waiting list for hospital dental treatment, and most of that work will be done under anaesthetic. And 3,790 children might not sound that much, but we only have a population of 5 million. A leading dentist and public health specialist in that article was cited as calling the state of children's teeth absolutely a scandal. So this graph shows why this particular case study site chose oral health as their case study. The graph shows that of the top 10 ambulatory sensitive conditions for this DHB, oral health or dental conditions was second only to asthma, for the total population at least. For Māori, it was upper respiratory infections, but it's up there. And this quote is from one of the case study participants from that study. And I wanted to use this quote for a number of reasons. To demonstrate that the need for innovative solutions, to show that it must be Māori that drive those solutions, but that collaboration to enact those solutions is also required. So where's the innovation? In this example, given the potential impact of poor oral health on our hospitals, innovation might come from thinking about our families differently, from recognising their strengths and their weaknesses, but recognising the challenges that those families face and adapting our services and our health messages accordingly. Where we might ask, are health promotion messages best delivered? And where are prevention and primary care interventions best undertaken? In this example, the solutions are seemingly as simple as taking mobile clinics to the communities themselves. Yes, to the schools and to the early childhood centres where our Māori children are, but also to the marae, to our gathering places where there are whānau members around them as well who are able to support and to reassure the children. The solutions might be to have the messages delivered by whānau members, by Māori, or at least, at the very least, by those who know and understand the lived realities of these communities. To have appointment processes and reminder systems that are flexible enough to cope with a very transient and oftentimes very reluctant population. The solutions are to make dental care and treatment available at such times as it suits Māori whānau, Māori families and their children themselves, and that might not be in school hours. Providing the means for community to take greater ownership of healthcare delivery and to have a role in directing and guiding that delivery is a strategy that we have seen, that we know works because we have seen it in the last 2 years as our country has steered its way through the COVID-19 pandemic. This is a quote from the recently appointed CEO of the Māori Health Authority. During the COVID-19 lockdown in March 2020, and since that time, it's been our iwi Māori, our tribes and our Māori people who have taken charge and led the response to COVID-19 in our communities. At the national and even the district health board level, our health system realised it did not have the knowledge, the on-the-ground intelligence and the wherewithal to deliver support and resource to our families in anything approaching a timely manner. From the outset of the pandemic, it's been our Māori leadership who mobilised and our Māori health providers who provided resources directly to whānau. And it's our Māori health providers who recently have ensured a vaccination strategy that has reached right into the so-called hard-to-reach populations. When provided with sufficient resourcing, without the paternalistic decision-making that directs a provider as to how their service must be delivered, and when freed from restrictive oversight, our Māori communities demonstrated their ability to be responsive, nimble and agile, meeting the needs of the community of whānau in the way that best suits those communities. So we know that an alternative is possible. We've lived through it. Can we suggest some?
We've just got 10 minutes, Dr. Boulton.
Thank you. I'm on my last slide. Woo! Can we suggest some principles to underpin a more sustainable health system? From a Māori perspective, the following principles, if not exhaustive, at least provide a starting point for building a sustainable health system, which supports improved health outcomes for Māori. First, the health system, as I've said, must acknowledge and respect an Indigenous worldview, realising that in that worldview, we hold a number of values that are critical to our health and wellbeing. Values such as our collectivity, the belief that we are inseparable from the physical environment, and that indeed these things sustain and support our wellbeing. Our health and wellbeing is about living a good life and balance with our wider natural world. That Māori have the right to determine their health and wellbeing needs is also critical. And then an understanding that we have the right to determine our own health and wellbeing, Māori must have the autonomy or agency to give effect to that right, whether that be space, time, resources, or a sustainable health system must provide ways for Māori to enact the changes necessary to address our health and wellbeing concerns. Our recent history with Māori representation in the health system has shown that it's not enough to have one or two Māori on a decision-making board and then expect anything significant to change for us. Real autonomy requires the relinquishing of power and privilege and creating forums, spaces and decision-making structures which then allow Māori to have an effective voice. And it must be Māori who develop and drive their own solutions. I, like many of my colleagues, think that the current set of reforms that we're going through hold some promise. We see elements within the reform that meet some of those foundational principles in terms of recognising an Indigenous worldview, recognise the importance of those features of our culture that keep us well, and embedding these features more deeply in how we think and plan and fund and deliver health services to our people. However, only time will tell if the proposed changes are sufficient and we manage to create a health system that meets the vision of Paiora, of a flourishing and thriving population. Nō reira, e ngā mana e ngā reo raurangatira mā, tēnā koutou, tēnā koutou, tēnā koutou katoa. Thank you.
Thank you very much for the presentation. We'll just come across to a couple of quick questions before we run out of time. It was a fabulous presentation, very thought-provoking. When developing healthcare for Indigenous populations, you mentioned strong links to spirituality and land. How would a health service objectively assess this and the level of effective implementation in healthcare services?
I think some of the things that we see here, so at the moment there is a hospital that has been built in Dunedin, and the local people there have been advising on the cultural practices or how culturally you can build that into a hospital campus. And so one of the things I've done, I don't know if this is the greatest example, but it's the one that sticks most in my mind about how we navigate through a hospital. And if you think about that, you know, it's quite a distressing state already. So one simple thing that they've done is just think about the layout of the land and where we have our morgue, so where we keep our what we call tupāpaku, our people who have passed on, is in a very different place to where, for example, you might keep your food, because to mix those two things are quite wrong. So it's about understanding how your cultural mores, your values can impact at a structural level where you position things. So that's just one example. Another example is the fact that we have taken healthcare services out onto our marae, onto our gathering places. So we're not necessarily expecting people for some treatments. Immunisation was a classic one during COVID-19. We didn't expect people to come into a hospital or a health service. We went out to the communities themselves, to their places where they feel safe and they are protected, they are under their maunga, they are on their land. I'm not sure if those are great examples, but yeah, those are two that come to mind.
Thank you. Natalie Bryant has asked, in Australia it feels like the Indigenous perspective is not ever privileged. Was there a key event or policy window that made whānau ora possible?
Yes, definitely, I would say. So that happened, and so there are a couple of things. In 2000, we had the legislation that this new legislation is just replacing, the New Zealand Public Health and Disability Act. And whānau ora was the goal within the Māori health policy. That got into that policy because we had, as part of our government at that time, a Māori leader from Wanganui who was at that time the Associate Minister of Health. And because of her, she had come out of, she had run a health service herself. She's very steeped in mātauranga Māori, our knowledge, so she knows whānau ora. She had enacted whānau ora in her health service prior to becoming a parliamentarian and then a Minister of Health. So she was able to get that term embedded into policy, into legislation, and that kind of is that 20-year journey that I talk about. So it was a long build-up, but now when you are in health services, people talk about whānau ora. They might not always understand the nuances and sophistication of that term, but it is embedded really as a concept within our health system. And so yes, I would say there was there were champions. We have often had champions to get these change, and those champions need to be at all levels, and particularly, of course, in government. And it's way easier for us. You know, we have one parliament. We don't have a series of states. We're much smaller. We have a treaty, so you know it's not always comparable, but it was a long journey.
Yep. And just the last question, 2 minutes to go, from Joe Wright. The sustainability diagram omits the economy as an explicit component, yet the socio-economic factors underlying the discrepancies in Maori health outcomes are well known. How does the Maori Health Board address the socio-economic factors?
Ooh, that's a great question.
90 seconds.
Right. Yeah, oh, sorry. So I think there was, in part of that diagram, there is an expectation that the social economic determinants of health will be, and boards are going to have to grapple with it. I think poverty is the overriding concern at the moment. So what a whānau, I wish I had more time. What a whānau ora approach does, it takes into account those social and economic determinants, and it works with the family at the stage that they are at. I don't know how they're going to do it, but we are all fascinated because it is a huge piece of work for them, and I think we just have to nail it. Yeah. Sorry, that was not a good answer. Great question, right?
Fantastic. Thank you so much. I would like to thank you for your presentation today, and if I may, for the opportunity to meet you and the mountains and the rivers, which are your ancestors. It has been incredibly insightful and thought-provoking. We're so very fortunate to have you join us today. Thank you very much.
Oh, you're welcome. Thank you.
Thanks very much, Dr. Boulton and Julia. 20 seconds to tell you it's time to pop out, rate the session with the survey, and then join us very shortly. Oh, sorry, we got the concurrent sessions start again now. So Thank you very much, and we'll see you shortly.